think after the ischemia trial, I think we have to ask question whether there is still a role of stress testing or ischemia testing, and whether this hypothesis of higher ischemia worse outcome still holds true, and is there still a need for looking at significant stenosis. And let us look at the 30 years of literature of stress echocardiography. The landscape of ischemic heart disease is quite complex. You have got a large group of patients who are asymptomatic and not a known coronary artery disease, and you do a risk scores to risk stratify them. Some of them present with new onset of chest pain. Some of them are having acute coronary syndrome. They get managed by the ECG and biomarkers, but others have got a stable angina. With on treatment, they go into a group of asymptomatic patients with a known coronary artery disease, and over the years, some of them again develop new onset of chest pain. Now, it is this group of patients where you need stress echocardiography to validate the symptoms, to diagnose, to prognosticate, and to take a decision of revascularization. Let us look at this patient, 32-year-old male, impaired glucose tolerance, non-smoker. He has an atypical, inconsistent exertional chest pain, and he has an intermediate pretest probability. Now, you have to validate that the symptoms are because of ischemia, and this is a stress echocardiography, and you can see that in the LAD territory, there is a large territory of akinesia. Now, this is more than 3 segments of akinesia, which fits into the definition of ischemia trial of moderate to severe ischemia, where the comparative definition for the nuclear was 10% and more, for the stress echo was 3 segments or more, and stress CMR was 3 segments or more. Now, if you look at the meta-analysis of echo versus nuclear for sensitivity and specificity, the exercise echo or a dobutamine stress echo have a higher specificity, as while the nuclear tests have a higher sensitivity. If we look at the dobutamine stress echo, as the number of vessels get involved, higher the number of vessels that get involved, the sensitivity of DSE increases tremendously. How is the choice of stress echo or stress ECG? The indication becomes stronger in the intermediate and high pretest probability when the ECG is uninterpretable, patient inability to exercise, resting regional wall motion, women, and also the patients who are revascularized. Now, echo is a very versatile modality, and you can improve the sensitivity and prognostic power of stress echocardiography by adding either doing the imaging on treadmill, or looking at LAD CFR, adding the contrast for LV opacification, adding contrast for myocardial perfusion, looking at the ischemic memory on a strain echocardiography, or doing an ergonomine testing to provoke a coronary spasm. Now, if you use on treadmill stress imaging as shown by the yellow bar, the sensitivity is far better than post treadmill at a little loss of specificity, but at a better accuracy. One can also look at the LAD by transthoracic echocardiography. Now, this is a patient with this kind of a lesion, and you can look at the LAD flow here. You can put a PW Doppler and gain the diastolic flow velocity time integral, and then give the IV adenosine and look at the increment in the diastolic flow and take the ratio to measure the LAD CFR. If you add the CFR data to the patients who have a normal stress echocardiography, those with a CFR less than 2 have a lower cumulative event-free survival. If you use contrast for LV opacification, you have got a better identification of the regional wall and systolic thickening. And the optimized trial showed that in the patients on dobutamine stress echocardiography, if you add LV opacification contrast as shown by red graphs, then the sensitivity and specificity improves in the difficult to interpret studies. If you use the contrast myocardial perfusion by using a high MI flash and adenosine and allow the myocardium to fill up the microbubbles, you can make out a qualitative interpretation of a subendocardial ischemia as seen in this particular patient. Now, myocardial contrast echocardiography improves the prognostic power, and one can look at this study where the patients with both abnormal wall motion and abnormal perfusion had the lowest event-free survival. If you look at the sensitivity and specificity of various stress echo modalities, then at wall motion, you have got a higher specificity. But if you add CFR, or if you add both wall motion and CFR, or if you add myocardial perfusion, the sensitivity improves at certain loss of specificity. If you look at the transverse strain on the one can see that in the first 1/3 of diastole, there is a rapid reduction in the strain values. However, patients who develop ischemia, either they have a post-systolic contraction or they have got a failure to relax, and that can be used as a sign of ischemia. As seen in this particular patient, one can see that the apical segment continue to show post-systolic shortening or failure for diastolic relaxation even 10 minutes post-exercise, and this is called as ischemic memory. What is the outcome of patients with a negative stress test? Now, these patients, if you look at the survival for the age-sex matched healthy population, patients with negative stress echocardiography have a very good survival. If you look at the annual event rates for death, MI, unstable angina, revascularization, they are there at around 0.5 to 0.9%, and at it almost equal to that seen with the negative stress MPI. And this prognostic utility is same for both men and women. What about the positive stress echocardiography? As you can see, the patient with a normal stress ECG but showing regional wall motion abnormality at peak exercise have a higher MES over the next follow-up years. So that shows that it improves the prognostic power of any stress modality. If you look for the dobutamine stress echo, then the patients with ischemia on dobutamine stress echo and ischemia plus scar on dobutamine stress echo have a worst event-free survival over the next 10 years. One can refine the outcome of positive stress echo by looking at the wall motion score index, which looks at the extent and severity of ischemia, the resting scar, and the behavior of end systolic volume at peak exercise. As the wall motion score index goes up, the cardiac event rates goes on increasing. So also, if you look at the patients at peak exercise do not show reduction in end systolic volume or show increase in the end systolic volume, they have a higher incidence of cardiac death, non-fatal MI, and late revascularization. What about the false negative test? Either they are because you have not given them a maximal workload, or there are still anti-anginals on the board, or the coronary disease may not have a physiological significance. Now, this was a study by Dr. Tom Marwick done many years back, and it showed that if the FFR is less than 0.75 and the vessel diameter is about 2.6, the dobutamine stress echo has a sensitivity of 90%. What about the outcome of false positives? Now, this is an interesting study from Mayo. When they look at the true positive stress echocardiography and look at their event-free survival, and then they looked at the false positive stress echoes. That means you have a regional wall motion abnormality at peak exercise, but a non-obstructive coronary artery disease. Interestingly, the cumulative survival follows the same path. That means having a false positive stress echocardiography is not a benign condition. It is an inoca, which could be related to unmasking a subclinical cardiomyopathy or an endothelial dysfunction, or it can be a variant of a Takotsubo cardiomyopathy. Can the stress echo be a gatekeeper for coronary angiography? Now, this is an interesting study where the patients were grouped depending upon the wall motion score index, and the cardiac event rates go on increasing as the wall motion score index go on increasing. But interestingly, whether the effect of revascularization is not seen so linearly. For the patients who had an intermediate wall score index, whether they were on optimal medical therapy or revascularized, there was not much difference in their cardiac event rates. While those with a wall motion score index more than 1.7, there was a significant reduction in the cardiac event rates when they were revascularized. So what is the advantage of stress echo? It has got excellent diagnostic performance. It is a low cost, easily available, time invested is less, patient comfort is paramount. The radiation, there is no radiation, there is no contrast use. The iodine contrast use, there is no environmental hazard. So the thing is, why stress echo is still relevant in post-ischemia? Because the stress echo identifies whether the patient's symptoms are due to coronary artery disease or ischemia. It can help to start and guide the optimal medical therapy. It can prognosticate, avoid unnecessary treatment, and so also it provides a physiological guidance for which vessel to intervene. And so also, for so many patients with chest pain, a negative stress test or stress echo gives a great cardiac reassurance. So also, stress echo finds out non-coronary causes of chest pain, like say hypertrophic cardiomyopathy, dissections, the dyspnea related to diastolic dysfunction, valvular disease, PH, myocarditis, infiltrative cardiomyopathies. And as we discussed, the INOCA patient, that means ischemia with non-obstructive coronary artery disease, which constituted 14% of patient in ischemia trial, which can be identified by stress echo, still indicate a increased cardiovascular risk. So why stress echo is still relevant? Because the concept of defining a high-risk plaque by anatomical imaging like CT, or looking at the extent of ischemia by the functional testing, these two concepts are not mutually exclusive, but they are complementary in the management of patients. Secondly, the PROMISE trial showed us that whether you start with the anatomical testing or with functional testing, the 2-year outcome of hard endpoint is the same. Rather, the functional arm has got less downstream revascularization. And so also in the ischemia trial, since this revascularization was done guided by ischemia, there was more durable angina relief as compared to the Courage trial population where the revascularization was done by anatomical testing. This way I rest my case about stress echocardiography. Thank you.